All attendees are in listen-only mode.
Hello, today's webinar series is Discharging Elders from Emergency Departments to Community, What You Need to Know. And just before we introduce the panel who will be speaking today, I just wanted to let you know that we at CFN recently submitted our request for funding for the next 5 years. On another note, now that we'll have a little bit more time not working on the proposal, we're going to be updating our website. As you know, many of the projects have been completing in the last 6 months to a year, and many more will complete over the next year. So you will start to see more projects showing up on our website with publications, webinars. You'll see keywords for searchability. And so please check back over the summer and you will see many of the projects updated. Eventually we'll be working on some other updates going forward so that you can do more searches with each other, different investigators and such. Today the webinar is being recorded and it will be available in 1 to 2 days. As you see from the screen on the red, that's where it will be posted. And we'll have a question and answer session at the end. And please submit your questions using the question functionality on GoToWebinar. And we will try to get to as many as possible. Both presenters have said that they would be willing to take questions that don't get answered at the end. And at the very end of the webinar, we will have that email ready for you in case you need to use it. So without further ado, the presenters today, actually there's the HQPs that are presenting as well as Marcel Imon and Marie-Josée Soroa. So Marcel is an emergency physician at CHU de Quebec. He's an associate professor in the Department of Family and Emergency Medicine at Laval University, co-leader of the CIHR-funded Canadian Emergency and Trauma Initiative in Elders. And Marie-Josée is an associate professor in the Department of Rehab at the Faculty of Medicine at Laval University, researcher at the Center of Excellence in Aging in Quebec, and has co-led the creation and work in Canadian Emergency Trauma Initiatives in Elders. So please go ahead and start your presentation.
Yes, just a second. Hi everybody, this is my first webinar as a presenter, and I haven't presented in English for a long time, so I hope I don't bug too much. So today I will speak first and Marcel will take over further down the line. So we are going to present you the results of a scoping review that was conducted over the past year. Before going any further, we really, Marcel and I, would like to thank a lot our two HQP, Nadine, Alain Boulet, and Geneviève Tremblay, who did a lot of the work while Marcel was saving lives in ED. And I was while I was teaching, so we really want to thank them very warmly. This CFN review takes place in the context of the Canadian Emergency and Trauma Initiative in Elders, which is a research program that was initiated a few years ago by Marcel and myself. We are located in 3 provinces and 8 EDs in Canada. And our aim is to increase our knowledge of the epidemiology, improve care and improve outcomes for community dwelling seniors who present in emergency departments with minor injuries. So this is the broader context of this scoping review. And you have, you have a few members of the teams on the picture here. Today we'll follow the usual steps of our presentation, so we'll go over quickly this slide. I will present a brief introduction, our objectives, and Marcel will take over with the methods of the scoping review and its results. At the end, in the question period, our Nadine and Geneviève, our HQPs, will participate to the discussion. So this slide here provides you with a little bit of context and issues that are addressed by the CITIe. Basically, emergency departments see a very large number of seniors who are community living, and so that represents around 400,000 injured seniors per year in Canada. And for whom the injuries obviously are not fatal, but that can limit their mobility and function in the year after the minor injury. To note, 70% of those seniors are discharged back home. So there's a small proportion that is hospitalized. And we are focusing our efforts on those who are returned home. Among what we found in the CITIe among those seniors is that the injury and the evaluation at the ED reveals a pre-frail or frail status. 33% of our seniors are considered pre-frail, and 13% of them, are considered frail. Those frailest, when we follow them after the ED visit, do have an increase in health services utilization in the 6 months at least following the injury. And this is both based on self-reports from seniors we follow and also based on provincial administrative data bank that we are studying at the moment. Our seniors return to ED or hospital in a proportion of 24-44%. This is work of Jacques Lee that has followed this issue in our seniors. The thing is, this consequence in terms of health service utilization, we think that is partly a consequence of a lack of implementation of guidelines for senior cares in ED. Another consequence of a possible lack of implementation of guidelines is the mobility decline and function in activity of daily living that we observe following a minor injury in our seniors. Here's a slide that summarizes the evidence about that. Shapiro, Wilbur in the US, Edwards from the study of osteoporotic fractures, and myself in 2013, we've shown in various samples of seniors with minor injuries that those seemingly minor injuries are associated with between 15 and 22% of functional decline in activities of daily living up to a year post-injury. In our own CITIe cohorts, pre-frail or frail seniors are at 10 times higher risk of functional decline within 6 months. Again, this functional consequence of injuries, we think that it could be partly due to the gap between the care guidelines that are promoted by the American Geriatric Society, the same here in Canada, the Cape and Amuk in Quebec, that basically tells clinicians to perform multidimensional assessments of seniors, so meaning to assess their functional level, their mobility, walking, vision abilities, falls, But those guidelines are lack implementation in EDs. There are very interesting Canadian reports on that issue. Erin Miller in Toronto found a few years ago that in fall-related injuries presenting at Toronto ED, that the seniors were not assessed at all for their risk of fall, and a very limited percentage of them were assessed with regards to their walking abilities, cognition, vision, function in ADLs, and up to 66% of them were not provided with any follow-up guidances. In the CIHI, in our cohort of over 3,000 seniors in Canada, we have tried to describe what was currently done in terms of ED care or post-ED recommendation for our specific population of seniors with minor injuries who are discharged back to home. So the slide here shows you the results of our first cohort. And represent the most frequent type of interventions that were performed. You see it according to different cities. But basically what is done currently is provide analgesia, which is an important aspect of injury, like to treat the pain. And after that, there's limited interventions. Obviously, orthopedic consults are done for patients with fractures as well as splinting or casting. Referral to family physician is performed in 20% or so of our seniors. And in terms of post-ED recommendation, we see that rest is among the most frequent, which is sometimes counter-therapeutic. People are recommended to return to emergency in about 15% of them, and some, but very few, are provided with or told to use a mobility aid. What we strikingly observe, and that concurs with our previous colleagues, is that there is no risk of fall that was performed. Anyway, that wasn't recorded in the medical charts nor in the research documents. No comprehensive assessment was performed, and there was very limited consultations done for rehab. So physio consults, for instance, with an ED is only 3%. Given what I just summarized, that we are facing a 16% rate of functional decline in our specific population, given the fact that our declining seniors are pre-frail or frail, and that is revealed and uncovered by the injury, and given the fact that the guidelines for senior care in ED are quite general and not specific to our population, we aim to identify and describe emergency and post-emergency interventions to help our pre-frail, frail seniors with injury to restore or maintain their function and mobility. So we performed a scoping review of the available scientific and great literature according to the following question, the one that is on the slide here. So our research question was, what are the efficient ED and post-ED community transition services to help injured community-dwelling seniors at risk of functional decline maintain their independence? So that's quite a question. That covers a broad array of interventions and in both ED and post-ED settings. We've come up with, you know, the usual PICO question that goes as followed. So our population was defined, as you might have guessed, as community dwelling persons age 65 and older, or potentially frail elderly with minor injury or a fall. We chose to include fallers in our population because injuries are in 70% of the cases, the injuries that present to EDs are results of fall. The intervention was quite a challenge to define because we cover a broad area of them. So basically ED discharge, obviously, primary care setting, because we know that around 20% of our population consult primary care with a minor injury. Ambulatory care, walk-in clinics, GP clinics were included. The concept of discharge planning after the ED visit was included. Community transition health services as a concept. Post-emergency treatment trajectories and post-injury health services were all included in potential interventions. And the outcomes, again, were quite broad. Our main focus is functional status as of CIHI researchers, but that can translate into autonomy, quality of life, risk of falling. We had an outcome on the health service utilization, so ED reattendance, hospitalization, institutionalization, sorry, injury and related care, and mortality was included. We excluded studies that were not in French or English, that targeted specific important health conditions. For instance, studies that would be on cardiac arrest or severe pulmonary diseases, things like that. Studies that involve no intervention, that did not focus on independent seniors. Studies on causes, etiology, risk factors only were excluded. When there was no ED discharge, that was excluded. Farm studies only were excluded, and studies on validation of instruments or screening tools were excluded. At this point, I will switch the mic to Marcel Aymon, who will take over the presentation.
Thank you, Marie-Josée. As you may see, we're switching voices here. It's going to be a more masculine voice, and I hope you'll be fine with it, because they are the lovely voice of Marie-Josée that you had for a while. So as Marie-Josée told you, we did a big scoping review, which is slightly different than doing systematic review and meta-analysis. So we were really broad. So over in the next few slides, I'm going to show you some of the methods of the research we did. So we did survey Pubmed as a first database. Here's the keywords. Keywords were selected using our research team that were in the second slide. So we did filter also for English and French. I'm not going to go in details over all of the mesh word we used, but that's how we did end up doing our research for Pubmed. Similar setting was done. We're using Embase database, and we did come up also with a couple of articles there. I'm going to give you the flow chart of the articles later on. But interestingly, when you do a big scoping review also, we wanted to tackle the gray literature and other sources that were important. There's a lot of booming information either on the web or in guidelines. So we went over a lot of guidelines and web. As you can see, I'm going to flash to the next slides. We had about 37 websites that were looked at. They're in French here. We want to practice your French if you're an Anglophone. So here you see some of the French word that we're giving you, and some of the country here in French. So as you can see, we were very broad, looking at Australia, Canada, Scotland, the UK. We also went over the States and see some of the website and guidelines that were available. So we wanted to be very broad as a scoping review to give you all the facts that's out there and what's missing for discharging your injured patient from the emergency department. So here's the flow chart and the process we use for our review of the literature and search. So on the left, as you can see on your screen, we have a screening and identification of the literature. We went over database, we came up with about roughly 3,000 titles, that needed to be screened. Great literature did provide about 16 guidelines. After removing duplicates, we're up to 2919 title that need to be screened and abstract. So after applying the exclusion in the last box at the title on your slide, at the bottom you can see after the exclusion of screening the article and abstract, we did exclude a fairly good bunch of them. It was a big work done by our team, and so we come up with having about 127 abstract and 4 articles that were screened and that were retrieved for analysis. And then we had further another exclusion round where we removed some of the articles after reading them. And at the end, as you can see in the pale box there at the bottom, that the studies included in our scoping review and qualitative synthesis was a number of 22. Out of those, systematic reviews with meta-analysis were 4, and without meta-analysis we had 2. We had mostly observational studies, a narrative review 3, and then interestingly, as you can see at the last line on the slide, gray literature did brought up about 10 important either guidelines or information that could be useful for doing our scoping review. So I'm going to be moving on with some of the results. When we analyzed the 22 available articles or guidelines, we came up with 2 important concepts that we're going to be used over the next few slides. At first, there was a trend for ED community transitions in all of the articles and guidelines that we looked at, and fall prevention care. So we'll start off with the ED prevention transition, give you some of the numbers there. So we had 10 studies that came up under the umbrella of the ED community transitions. So mostly were gray literature, as you can see, 50% of them. We had a bit of systematic review there. I'm giving you the breakdown of those ED transition services by type of intervention that were available. Anyway, obviously there's an overlap. They're not mutually exclusive. And the first one is on the left is a comprehensive geriatric assessment, CGA, and then you go on to the right, moving from discharge planning, telephone follow-up, as you can see them, to GP liaison, care bundle, and we'll go over there more in detail in the next couple of slides, but that gives you the number we had for that first key concept. So if we go more detail to give you a bit more take-home message here, so comprehensive geriatric assessment is what we call multidimensional, physical, functional, cognitive, interdisciplinary assessment, and it needs to be developed in coordination with the discharge care plan. So when we look at the results of that comprehensive geriatric assessment, basically, we see that obviously now most of the published literature show a so-so benefit in applying this in the emergency department with discharge patient. But the gray literature did say there's probably a good benefit, especially in the UK guidelines that mention a lot of possible benefit in doing so in patients that are discharged from the emergency department. Then if we switch to discharge planning management, care coordination to assist the transition from ED community, then it was recommended by the Emergency Nurse Association for the States and had a mixed result on review of whether or not it does influence the return to ED. So it seemed to be interesting, maybe well received by population that we're looking at, or the ED professional, but have mixed result on the return to ED, which is an important concept here of patient not coming back to emerge after we discharge with an injury. Telephone follow-up, interestingly, it does decrease when you look at literature the early ED readmission, but long-term and moderate, mid-term effect are not that great, but after in the first week or so after discharge, seemed to be a very interesting aspect of preventing a return to ED when you're having telephone follow-up after an ED visit. Community referrals, interestingly, there is a need, it does decrease the needs for hospital admission when you're trying to get more community referrals. So that could be very interesting. So instead of having a patient going up for an admission after that minor injury, having a good community referral could probably decrease it and has the ability to get the patient back home or in the community. But there was no assessment of patient outcome in that community referral. So whether or not it does influence, the patient mobility and affect his functional status, we're not sure, but it does affect, though, the health services need, especially the admission one. The brief risk assessment screening tool, as you see, is the last line. It's a rapid tool that's been, promote maybe to be used in the ED to detect functional and cognitive social impairments in patients that we see in ED. There's been washy-washy result concerning that as whether or not it is efficient. An interesting point, though, it was seen that in some of the articles that was reviewed, there was a difficulty in implementing this within the ED department. So there's always an issue, obviously, of having an ED, time pressure, busy environment, and trying to get the right tool at the right place to be able to screen your patient and give them the tailored services they need afterwards. So we move forward on other type of intervention. Discharge instruction education. Interestingly, patient that got written or computer-generated or even verbal instruction, this seems to be increasing the patient, I should say, the patient satisfaction with the services and may increase the follow-up adherence to what you're saying, but we don't know down the road if it does help for patient outcomes relating to either functional status or mobility afterwards. But there seems to be an interest there and probably a route to evaluate in your own emergency department or your setting. As for health visitor prescription assistance, there is not much results or outcome that relates in our department as whether or not it does help prevent either mobility or functional decline afterwards. Interestingly, there is a very inconsistent result regarding the geriatric consultation services within the emergency department, but of note there was only 2 publication relating to the usefulness of geriatric consultation services within the emergency department. And there we have a bit of a mixed result there. So it's difficult to settle of whether or not it is a useful avenue that you can use in your ED as an intervention to improve the outcomes of the minor injured elders. ED-made appointments. So as an emergency physician, I'm booking up follow-up appointments for my patient I see, which is probably not a usual practice, especially in Quebec. We don't usually practice that. Maybe some of a more advanced, or say, practice in other community, but it is of a slight benefit. So basically, there is a higher adherence of the patient when you do take the appointment for them. Whether or not it does affect the functional decline afterwards, we don't have data to back this, and it's difficult to decide whether or not we should recommend it as an avenue. But it's something that we should probably keep in mind in our toolbox for some of the patient. As we move along again in other categories, we have GP liaison. We only have 2 articles that we're discussing that. So this is more a real GP fast track to get the patient seen by their general practitioner after a minor injury or fall. It may decrease the return to ED, but we don't know on long-term patient outcome whether or not it affects the functional mobility as we go mid or long-term for those patients. Care bundles, it does increase satisfaction. So care bundles is having a predetermined combination of selective intervention to improve the discharge process, and it does increase the satisfaction of patient or health professionals, but so far studies haven't shown a decrease of return to ED. So patient may be more satisfied, but it doesn't seem to be less inclined not coming back, basically. Transportation assistance and group appointments had not very lot of data to back their use within the ED or after post-ED recommendation. So that was the end of the first concept that were ED transition care. If we're looking at the second concept, which was more at fall prevention program, then we had 12 articles. So 12 articles that will fit under that category. As you can see here, great literature, although was very important here again to look over that scoping review with nearly 40% of all of the published information on the fall prevention intervention. We had systematic review. Mostly descriptive reviews were looked at for that part of our scoping review. So if we go on into the type of fall prevention intervention for elders after an injury or fall, then we had the multifactorial intervention where we have the bunch of and the bulk of all of the publication. It could be an effective avenue, but the effect may be marginal, put it that way. So it may be interesting, but the effect can be marginal within the evidence. So it's an interesting avenue, but may not be the best avenue to go with after the ED. Exercise, interestingly, exercise seems to be high up there with 8 publications, either supervised, individual, or in group, home-based or not. It seems to be decreasing falls would give, and interestingly give you a number needed to treat of 15. If you are not familiar with number needed to treat, is actually the number of patients you need to treat to prevent a fall. So you need to send 15 patients to exercise group or promote exercise in 15 patients to avoid one fall further after a discharge from the emergency department. So that could be very useful to look in your community after a needy assessment. Home environment, assistive technology, as you can see there, it's going to patient home and having their home assessed for any assistive technology or device they may need. And this seems to be consistent though in the result that there's a drop of 20% risk of falling. And mostly the high risk. May not be as much in the low risk category, so the low risk category may not benefit from having a home visit, put it that way, to be assessed by the occupational therapist, see if there's any change that could be done in their home to make it more safer. But the high risk and moderate risk may be of interest, a group that you should tackle with having a home visit or assistive technology in your community. Multifactorial risk assessment, it does give you a slight benefit, but so far we don't have the data to back it up and recommend it as a go-go intervention. If we move forward, vision assessment and correction and referral. I'm sorry if I pause here, Marie-Josée making funny faces, try to make me laugh, so sorry about that. So I see there's a lot of people on the line, about 141, so the emerge must be overcrowding. People are all listening instead of attending patient care. So I'm making my own joke now that I have Marie-Josée is laughing at me there. Vision assessment and correction referral. Okay, I mean, this is kind of a basic one, is that, obviously if you improve the vision of patient either by using surgery. Surgery is just below the vision assessment, but it relates to mostly ophthalmology surgery, so cataract surgery and all those type of things. So if you do improve the vision, obviously it does decrease the number of fall, and it does improve your outcome for mobility and functional status. Medication, we all know that. It's kind of part of the comprehensive geriatric assessment culture and philosophy. There is a big part here, and all of the data are going the same direction, is that if you do look at medication, either removing medication or supplementing some of the medication, here we'll put down vitamin D and some of the hormone replacement therapy medication review, as I just said. This is actually quite important and should probably be assessed either in ED or post-ED according to your setting. It does decrease the risk of functional decline or either return to ED in your community. And one of the last line is looking at the type of intervention here. So bear with me, we'll come up with we're getting to the end of this webinar. So education and knowledge, it's always good to do, but it's inconclusive as to whether or not it does help. But it's always good to get more knowledge and empowerment to your patient. But we're not sure if it does improve patient outcome in mid and long term. Psychological intervention. This is where I stumble on the word. I'm usually just happy that I'd stumble on that one. So it's more looking at the fear of falling. So fear of falling of your patient and see if any therapy regarding that could help. Not sure, slightly mixed result there. It may improve. It's maybe always good to do as part of a comprehensive assessment, but you know, as a solely intervention, it may not be that beneficial. Nutrition therapy and paramedic referral pathway, we didn't have a lot of data on that, so we cannot say any recommendation regarding those type of intervention. So here is the, whoops, sorry, there was a slight mix-up in my slide, but that's okay. I think it's part of Marie-José word that she just changed the slide before we went online. So I'm just want to show you here the overlapping of source article and the systematic review. We had a bit of question as whether or not, no, there is a couple of systematic review that were looking at scoping review, and we try to see if there was all looking at the same intervention or if they were different intervention. As you see here, this is the kind of map we do that shows different systematic review, and the number here is the same reference they're quoting basically, and it goes from on your left from the ED post-ED community transition services to fall prevention, and you see that, you know, overall there is no kind of 100% overlap. We do find interesting avenues in all of the systematic review when we look at our scoping review. So I'm going to switch to model of care and transition. This is to try to do a big model of all of the scoping reviews. It's kind of a toolbox. I call it the toolbox for the dumb emergency physician, basically, because, you know, I won't go into that. No, that's okay. So the model of care transition for ED community, as you go from the left to the right, goes from paramedic, so maybe useful, but we don't have enough data. And then you go from ED, where we try to settle all of the intervention that's been reviewed by a scoping review, including in the middle kind of discharge planning, care coordination. There's multifactorial fall assessment, and then you have a number there, and all the details I just given in the previous slides about, you know, usefulness of them. But that's kind of a sum up slide that will give you where all of the evidence and all of the published and unpublished and great literature will fall. And then on the right, actually, you do have what's after the ED, so fall prevention, intervention, and community or transition care also are there. So research gap. So one of the main objectives of doing also a scoping review, see is there any research gap, challenge, and strength of, well, what we did. So the research gap actually is one important one, is that there is no specific research on effectiveness of the intervention to target, you know, the potential frail or pre-frail elders after an acute injury or fall. And actually, we should probably say there is no tailored intervention according to the specific risk level. So there is a big issue here that if you go back to our model that we just said, is that the model of care and transition is that in ED actually we are in needs of better stratifying the patient risk and then tailor the information and tailor the intervention afterwards, either in community or ED, to that specific risk. And none of what we've looked at in a scoping review was actually looking at tailored approach, but it was more like a global approach. So we're in, there is no specific research on really in target potential pre-frail or frail elders after that acute injury and fall. There is no comprehensive knowledge during elders presenting an ED in relation to their potential frailty state and risk factor. And there is actually a lack of clear and coordinate care in the continuum of for frail seniors discharged from the ED following an injury or fall. One of the strengths that we have from our scoping review, we do believe that we had an exhaustive list of potential intervention ED, especially that we looked and we decided to look at all of the great literature, and our numbers are showing that there was a lot of information there that were I should say important or significant in doing that scoping review. We did, as I just said, a large scope of assessment intervention, and we highlighted some of the knowledge gap intervention as we went along that presentation. Some of the challenge also that we had is there is a complexity of the health services intervention when you look at all of the literature, and we just showed you a glimpse here in that 30-minute presentation. But obviously, if you read the article, eventually you'll see there's a lot of complex and health service intervention and a lot of different avenues that have been studied. There's an heterogeneity in methods, population, intervention. There's a couple of limitations in the methods in the clinical trials. Efficacy and efficiency of intervention are hardly comparable when we look at them, so it's quite difficult to pull up a result and do a real quantitative meta-analysis. Outcomes do change between studies and are difficult also to merge together. There's a lack of data on important patient-related outcome, and this is interesting. Very patient-centered outcomes seems to be missing from some of the studies that have been fetched from our review. And there are also some lack connection between intervention made in the ED and versus the community. So take-home message. And if people don't know me, I'm on the right side of the slide. That's my representation of myself in a comic strip. So limited high-quality evidence of optimal transition and services following ED discharge. It is, I wouldn't say all over the place, but after doing that scoping review, I feel like I'm in a good place as an emergency physician, because it seems as sometimes it could be crazy in the emerge when we see a patient. So, it's all over the place, but away, different avenues. What we can take home message from a review is that, the comprehensive geriatric assessment kind of culture and philosophy seem to be there, although it may be difficult to implement the ED, and it may be interesting to look for. Discharge planning and care coordination is interesting and should probably be looked forward as there is evidence that maybe it is useful. Referral to community services. Here we're also talking about physical activities, group. It should be probably tailored to individual needs, and that's what actually is probably missing. Is that we need to assess the risk of patient within the ED then tailored to individual needs, and that will probably be more beneficial down the road in mid long term. And as my last slide is coming up, I would advocate that ED professional, people in my emerge, should be aware, knowledgeable of available community. They should also be able to transfer that knowledge to the patient. So we did show that some of the written information, either computer-generated information, should be available for discharging seniors, and is sometimes lacking. Seniors go back home and have actually probably no clue what happened in the emergency department. It was quick, busy, high turnover, and they're not sure exactly. So there could be, ED professionals should probably improve their care by adding an extra layer to their toolbox, having knowledge transfer to the patient. And also there's a need to probably an improved coordination service along the continuum of care for the injured community seniors, and it should emphasize probably on primary and secondary preventive intervention in the future. So without further ado, like Carol has said, we're going to take some questions.
Yes, thank you to both of you for an excellent presentation. And for everyone in the audience, please continue to add questions through using the questions in the GoToWebinar. I do have some questions, and you guys can figure out which one will answer them. One of the first ones is, was home care referrals or CCAC or consultants examined as an intervention?
Can you just repeat the question? Sorry,
Yeah,
we had a lag in the sound.
Okay. Was home care or CCA referrals or consults examined as an intervention?
For that, I will turn the mic to Geneviève first, who read in details all the articles, and we may complement each other.
Okay, so home care was often cited in papers we selected, but we tried to group intervention in community referrals. That home care was included in community referrals, so we did not evaluated this single intervention, we grouped them with other community referrals like OT visits and physiotherapist visits and other health professional visits at home.
So yes, it was part of the, it was in some of the papers that we went through. Yes.
Does that answer your question, or?
Hello?
I'll wait to see if somebody says that you've answered their question. I believe, too, that home care is defined differently in every province across Canada. So some have, like, CCACs, and others do not have that availability and would just have separate services. So that might be a part.
Absolutely. There's a large variety of types of home services. There are sometimes public, private, and according to the environment, the process may vary. So there's a great variety. And that was a challenge because in defining the question and the intervention, Nadine and Geneviève and all the team, we had to, I mean, it was a bit of a challenge to identify that concept for the literature search and not missing anything.
Okay, and Margaret got back. She was the one that asked the question. She says, yes, that is okay. I had meant more in your examination of the current state of emergency department interventions you presented at the start of the presentation. So moving on to the next one. This one is about the exercise intervention and reviewing home adaptation. Can you review which was more effective for falls prevention? I heard the number 50 referrals before, 1 reduction in a fall. Is that correct?
Number to treat, you mean?
Oh, number to treat for physical activity. Yeah, that was correct. So you need to refer, you need to get, 15 elders either referred or doing exercise after fall to prevent one from falling in the future. So that was a number to treat, which actually is very good because aspirin for heart attack is 16. And we do give aspirin to all of the patients who had a heart attack. So, I mean, so it's about similar if you get patient up and do physical activities after a fall or an injury, and you can, you're able to send them either to physical activity group or a physical home-based program. You have to look in your community, but it's similar to giving an aspirin as a result to the acute MI or myocardial infarct. So that could be very useful and is quite available when you look around. As an emergency physician, I can tell you sometimes we're disconnected from the community, and that was part of the scoping review. Key finding is that we need to be more connected and not just in a place where a patient comes in and they come in and they go out very easily, but we need to be a kind of a continuum of care more than just a place where they parachute.
Okay, as an ED clinician, do you observe in your daily practice the gaps in interventions that are identified in this review? What is currently done in Canadian emergency departments? Can you improve knowledge transfer between researchers and clinicians? That's a good question.
Yeah, it's a long one actually.
Take more than 1 minute.
Yeah. So there is a bit of a cultural thing here, is that as an ED clinician, I can tell you that looking around in different aspects of Canada, there is different approach. ED physicians are usually, I should say, for the past 10 years, have been more prone in changing their practice. But beforehand, they usually really tackled, the problem. You have an injury, you're in pain, so they were treating injury, treating the patient pain with analgesia, and they were just sending them home. So they're just fixing what's broken. And now over the past, I should say, probably 5 or 10 years, but mostly the last 5 years, we've seen a change in all of the culture of emergency physician regarding the geriatric trauma where, okay, we need to do more and we need probably to fill the gap of that patient is coming in, yes, with an injury, but you know, the injury is a consequences of something else, or we need to prevent further decline or further injury or return to ED. So, I mean, there is a gap. That gap is filling slowly. It is probably getting a bit more increased awareness over the last years. And you want to add something, Angela?
If I may add, there's also, Marcel is talking about the culture that is slowly, culture of care that is slowly changing. There's one thing to note is that training of ED physicians as up to a few years ago not included a specific geriatric component, and that was only added, what, Marcel, a few years ago?
Yeah, it was in the early 2000s that we added really a geriatric component. Actually, there is now kind of a geri module you can do from the Association of Emergency Physicians. Has been there for the past 5 years, if I'm correct. But you know, that's something that's been usually not part of kind of the emergency physician culture. And with, you know, the tsunami, the silver tsunami coming and hitting our emergency department, we obviously need to fill quickly that gap, and that's why we endeavor ourselves as a team to fill that gap. So what can be improved to knowledge transfer actually between researcher and clinician? I think I did tackle that, answer that question by saying that, you know, for years we thought we were kind of a silo in ourselves treating patient for an acute injury, and you know, a bit disconnected from the rest of the community, the pre and post emergency visit. And I think that now we need to be more anchored with the continuum of care, that, you know, there's a pre-ED and a post-ED that needs to be part of your treatment plan as an emergency physician or an emergency professional.
Yeah, and if I may add, we are going to start another very large research project, actually a clinical trial, that will be based on increased knowledge transfer to EDs on the topics that we've just spoken, and in conjunction with interventions related to transitioning from ED to community. And one important component of that intervention will be physical activity or exercise. In a few years, we'll let you know.
So stay tuned for the phase 2. Yeah.
Okay. And following up to that, there's quite a few questions that have come up around the same theme, and it's basically about the role of the PT, and it's basically asking for your opinion. Would it be efficient to send independent seniors to a geriatrician or a physical therapist, or both, following a fall or an injury?
I will start by saying that in ED phase, the issue is always the risk assessment, which has not been done, and that's part of a bit of the gap that, if I come back to the previous question, the gap that's still lying there, that the emergency physician haven't done a real good risk assessment work over the past years, and I think that's going to be the first answer. First part of the answer is that you need to do the good risk stratification of your patient. Tools may have been lacking or been not perfect yet, but still now doing a risk assessment will help you decide whether or not you should send them for a geriatrician consultation or a physical therapist. And we've been applying probably global measures to a individual patient. We need now to be more tailored to the patient needs and the patient risk to be able to decide whether or not I'm going to send them for, you know, the CGA or for just, you know, physical exercise.
And if I may add, a geriatrician may be available in the room, but geriatricians are extremely rare in the community. There's actually one community geriatrician in the whole province of Quebec. So talking about knowledge transfer, so general practitioners have to be also trained with seniors' issues. I would like to point out that one of the CITI students is doing a project on analyzing data on patients that we have followed who have accessed or not physiotherapy after the injury. And well, this is still an ongoing study, but only based on cohort data, we observe that physiotherapists are most effective among our most severely injured patients. So this reinforces the risk stratification that Marcel was just talking about.
Okay. You have a good point about the number of geriatricians across Canada. They are in scarce supply. There is just, I think, one last question, and this is really a comment about what you just said in terms of the team to respond. And out in Vancouver, Debbie Hall is saying that there's a quick response team that includes nursing and OT. PT is not included in this group. Do you have an opinion on that? Is basically what they're asking. So OT versus PT, I guess.
Yeah. Usually we see OTs involved in more severely impaired patients. Overall, there are variations in that, but overall OTs are involved in the EDs with the most severely frail or sick patients. And our target population here within the CITI and our further work are the pre-frail patients who are still independent but at risk of functional decline. So we're, in terms of health condition, our target population is a bit less impaired than what most of OT sees.
Okay. So I think that wraps it up for today. I think most of the questions have been answered. There's probably 4 or 5, and I know you've left your email on the slide, the last slide that you had, in case somebody wanted to contact you. I think there's probably a few questions here that really aren't questions and are just saying very interesting and informative webinar. Please thank the presenter. So again, thank you very much for presenting today, and it was an excellent presentation. So just moving forward on your slide is just to look at the upcoming webinars that are coming. I know it's vacation time, but we have one on July 20th and August 17th. Both of them will be really excellent webinars, and hope everyone can attend. And there is a brief survey that will pop up, and hopefully you can provide some feedback to us so that we can improve the webinar series. So somebody's asking about the last slide with the email address, and I think I may have that near the end here. I think it was that one there. Can you see that one?
There. Yeah. Yeah. There you go.
That one. It's coming. There. It's the one in blue, right. Can you see it on my screen, Jeremy? Okay. So it's ceti.mobility@gmail.com. So hopefully you'll get a few questions answered in that regard, as it's almost 1 o'clock. So hope to see everyone at the next webinar. Have a good day, and again, thank you for coming on, and thank you for presenting. That concludes today's webinar.
Thanks.
Thanks.